interoperability standards in healthcare and hospital reference architectures. He conducts healthcare service research for private and public organizations. He worked for the US to begin with the presentation.
Okay, well, thank you very much. I appreciate that. And let me encourage people to interrupt me. You raise a hand and the moderator can can interrupt if you would like. This could be a dialogue. And then there'll also be time for questions at the end. I'm showing two things right now. I want to, the presentation is, as you can see on your screen, Global COVID-19 Mass Vaccination Campaigns, Best Practices. And this is a paper that the Healthcare Forum wrote and published in middle of February. And I'll go into some details about that. I want to show you how easy it is to get to it, because we'll go through a lot of things today. But it's easier if you have the paper itself, and it's very easy to get to this paper. And I'm going to show you how to do it. So if you just type into your browser, I'll make this full screen. You type into your browser www.opengroup.org and hit return, then the home page will come up for the Open Group. And it's right here at the top right. Right here at the top right under latest announcements. You don't even have to log in. You don't have to be a member. You don't have to fill out any kind of information about your name, your address, what organization you work from. It's information we would like. And for all other products that we publish, which are open and free, other white papers, I should say, all you have to do is log in and then go to the library right here. And you can download whatever you want once you've identified yourself. We thought, however, that for something as current, as important, as global as the COVID-19 pandemic, we would make this paper as easy to get to as possible. So all you have to do, and this is true of anyone who has a browser, is go to www.opengroup.org, go up here to latest announcements, and just click on it, and boom, you're there. The paper itself is about 20 some pages long, and it begins by discussing the Open Group and the Open Group Healthcare Forum. One thing it does mention is some of the things that we are involved in, and I was just talking to Alvin before the meeting started, to Dr. Marcello, and I promised I'd mention both at the beginning and at the end a little bit about some of the other things that we're doing in addition to this work that we did on the COVID vaccine, mass vaccination campaigns. We are a relatively small forum of enterprise architects from relatively large companies like IBM and DXC, Gainwell in the US, Fujitsu is a member, and others, Philips. But we are increasingly attracting hospital systems because we're working on a hospital reference architecture, and we're basing that. It's actually described down here in our current work here. We're working with our Dutch colleagues who work for an organization called NICTIS, which is a government it's affiliated with the Ministry of Health, and they're really responsible for all of the IT, or what they call in Europe ICT, capabilities. And they've developed over the last 10 years a hospital reference architecture, which is called the ZERA. And we could go, if there's time, I can take you to the website. But the point is, what we're doing is we're translating this hospital reference architecture into English. It's now in Dutch, but it's been developed over the last 10 years by all the hospitals in the Netherlands, and it's used. And so we considered it, after reviewing all of the hospital reference architectures that we could find, that it was a best practice reference architecture. Our intent is to translate it into English and publish that, and B, to create a globally relevant, as you can see here, hospital reference architecture. Because obviously this ZERA, having been developed in the Netherlands, does not necessarily have a global orientation. That's what we will be adding. So anyone who has an interest in this, I would encourage you to contact me. My email information will be at the end of this presentation. We also are the stewards of the FIM, the Federal Health Information Model. You can read about that under the Open Group Healthcare Forum, or you can go to www.fhim.org. That in and of itself is probably worth showing, because there's so much information here. It's all about boundaryless information flow. I don't know if this is in the way, this bar. I'll try to move it. Okay. It's all about the ability to get information to flow from one place to another, which essentially is digital health. And the FIM is for managers, the executives who make decisions, is for modelers, the people who create the models, it's for informaticists, those who are focused on the semantics, which are very key, and then for developers as well, those who are developing APIs on the technology layer and the application layer. If you think about an EA orientation like TOGAF. Lots of information here. You go to the model, for example, there are 40-some categories. If you look under allergies, there's UML models that go into a great deal of detail on what falls under that. So this is really an open asset, and it's an opportunity waiting for people to come along and use it. The US government spent millions of dollars on it in 10 years and then decided, we're going to go somewhere else. They used it for DOD, Department of Defense, and the Veterans Administration so they could communicate. And we became the stewards, and we'd love to talk to other organizations that are interested in developing a common information model. So let me then, with that as background, move to the actual presentation. Let's see if I can, yeah, okay. So as I mentioned, we published this paper that I just showed you on February 19th. It's available at the web address up here. And that's the cover. On February the 23rd, 4 days later, we published a blog on architecting COVID-19 mass vaccination campaigns using best practices. So if you want to get a more brief description of what is in the paper, you might want to look at the blog first. And then the paper, of course, is only about 20 pages, so you can go there as well. Where I'm going to start this is with the HERA, the Health Enterprise Reference Architecture that the Open Group has created as a framework. It's can be used with TOGAF and with ArchiMate. In a way, it is a layered framework as well, but it's presented as a cloverleaf where one begins with the idea of plan. You plan first if you want to do something, or if you want to make a change in an organization, or if you want to architect a part of the organization. So you want to plan what you're doing, and that involves starting with what are the vision, mission and goals that one has for either a large organization or for more typically a part of the organization. And our focus here is typically, how do you solve business problems using information technology? So what are the vision, mission, and goals? What strategies does one lay out in order to set on one's journey? What capabilities are needed? What is the digital or otherwise transformation portfolio? And then how does that link? We get into the build and the architectural model. How does that link to the business processes? There's a lot of discussion in TOGAF and in other architectures about business processes. You have OMG, which is focused very much on business processes, and the new BPM Plus work that they're doing there. Tied into this are terms like business functions, business services, objects, things, terms that one finds not just in TOGAF, but also in ArchiMate, the modeling language. And then the focus becomes on health information harmonization, which really gets into that need for a common information model or common standards so people can talk to each other. And then the applications that are developed in order to use that information and the underlying technology. So you could talk about hardware and software. FHIR would fall under here as an application, for instance. And then, of course, there's the whole implementation aspect and the need to run the business, to operate the business or the project, to measure key performance indicators, to analyze the data that one collects, and to evolve in an agile manner. The whole thing is focused on people. It's person-centric, and on the idea of continuous improvement, continuous quality improvement. And there's a security band around it, as you can see as well, that focuses on the need for security of information. Now, the paper that I showed you could be divided into, it can be thought of in terms of this model. So the introduction of the paper focuses on objectives, on goals, on mission, on the audience, on the background. And we'll be going through this section by section here in this presentation. The second chapter of the paper focuses on strategy, on these various elements that you see under strategy, which we'll be discussing, and then moves on to not just capability planning, but the development of the capabilities that are necessary in order to run, and in order to set up the ability to run a mass vaccination campaign. There then is a fourth chapter on monitoring systems. There is a great need to collect information during the process, before a vaccination campaign during and after as well. And we'll go into that. The need for following the supply chain, for collecting administrative data when you vaccinate people, and for doing post-campaign analyses like pharmacovigilance studies, which are critical for assessing the real world efficacy and safety of vaccines. You know, all that work had been done in clinical trials, but it's only when you go out and you vaccinate the world, which is what we're trying to do, that we get that real kind of data. Then, of course, this bracket here just focuses on the fact that the run dimension or pod of the HERA is focused on actually implementing the rollout. So one starts with the idea that there's a problem here. And of course, as we know, we've been living under something that no one living has ever experienced, and that is a worldwide, it's a pandemic. And it was during a meeting that the executive board of the Open Group had back in the fall, in October, late October of 2020, that the executive board members said, well, what can we do as a standard organization to respond to the fact that the world is in the throes of this pandemic? And that at that time, as you recall, many countries were facing second or even third surges. And of course, in the US, we had a terrible surge following this, and in other places as well. India currently is facing a terrible surge. And so we got together as a forum, and we decided that what we could do best is that we knew that vaccines, we didn't know when in October, obviously in late October, we didn't know when the vaccines were going to be approved, but we knew that were going to be approved pretty soon. So our focus became, all right, let's look at best practices around mass vaccination campaigns, which have been around for a couple of hundred years since Edward Jenner discovered the smallpox vaccine. There have been, as you know, and in some developing countries, these campaigns are more developed than in developed countries. There's a lot of information on best practices. And so the forum decided that we would bear down and look at not just one country's approach to mass vaccination, but look at a global approach to vaccination. And so we wrote this best practice guide or this paper. And the intended audience, so that was the objective here. The audience that we had in mind is really broad. Within a country, it's the national leaders who are making decisions. It is the regional leaders who are working with the national leaders and also with the local authorities. So it's really those three broad audiences, the national, the regional, and the local authorities. And then there are, as you know, hundreds of private sector partners, the people involved in transportation, in boxing up supplies, in finding volunteers. And so there's a lot of audiences involved. And the need to, we'll get to this in a second, the need for those organizations to collaborate is quite essential. I think I'll skip over any more detail there and get right into the second part of the paper, which follows this enterprise architecture framework, which is focusing on strategy and planning for strategy. And, you know, one of the first questions people need to ask is, who has authority? Where are the rules, roles, and responsibilities within a campaign? And and it's key really to figure out at the highest level what the authority is, and at the middle level who has the authority and what decisions they can make, and then at the lower level, at the local level, what kind of decisions they can make. So having a clear plan for who the decision makers are and where the responsibilities lie, what individuals and what organizations have what roles, and then by rules and what responsibilities associated with those roles. And then the idea about rules is that within every country, there's regulations, and they're going to differ. And that's why we didn't get into too much detail here. The rules in one country, the regulations, the regulatory framework is going to be different than in another country. And for any particular country, going to want to work within the regulatory framework that applies within that country, and sometimes within a region, and even sometimes at a local level. So the next point is collaboration, and I mentioned this just a moment ago. It's really key that authorities, the jurisdictional authorities, work with many, many public and private partners. The World Economic Forum has considered this to be so important, this need for collaboration, that they actually wrote that the sum of many individual actions will not add up to a sufficient response to the COVID-19 pandemic. Only coordinated action at exceptional speed and scale can mitigate the risk of this unprecedented crisis. That's what they wrote back in, last year. And where we've seen success in mass vaccination plans, Israel, for example, and there are other countries. And within the US, which I know personally best, it's typically the states that have this collaboration among the different decision makers that are most successful, as reflected in the percentage of the population, especially the high-risk population, that gets vaccinated. As you know, identifying who the critical populations are within a country is key. Oftentimes, most of the time, I would venture to say, the the elderly populations and the populations at the highest risk, so perhaps with 2 or more comorbidities, receive the vaccination first. And then there's a second tier and a third tier and so forth. This, as with a lot of things in vaccination campaigns, can vary. There have been places where vaccine was available, but people weren't there. And so they started vaccinating anyone who came, who wanted a vaccine. And so this is really, again, left to the local authorities. It's also closely tied to the phased approach, which we'll talk to in a minute, which has to do with the supply of vaccine. Vaccination sites are very critical, and in some countries, there may be an infrastructure where the most logical place to provide vaccine is in a primary care network that's distributed around the country. The UK thought that that was probably the way to do it, because the National Health Service does in fact have that kind of distribution. And yet what a lot of countries have found is that mass vaccine clinics are really key to start and to vaccinate a large number of people. Okay, so selecting the sites is important. The vaccination providers, this is really a very large staff that relates also to vaccine administrative capacity. The vaccination providers obviously would be those who give the shots and those who take down the data. I got my vaccine, my second dose, and I went to one of the hospitals and they had it all laid out and planned. And we sat in a row in columns, and there were two people who pushed a cart, and they both were vaccinating, the person in front and the person in the back, and they'd collect their information on their phones. And those individuals have to be, in many places, licensed and trained. And that's part of the reason why it takes time to get up and running, and why we've seen relatively low vaccination rates at first and then much higher vaccination rates as the campaigns become more established. The vaccine administration capacity or administrative capacity is really for planning purposes, what is the largest number of vaccinations per day that you think can be delivered in a particular place? This helps in the determination of where the sites need to be distributed according to the need. Depending where one lives, you can imagine the need for help in whether it's at the vaccination site. People, suppose, as in my case, I parked in a parking garage. There were people there who showed me where to go, who walked with me, who told me what line to get into. These are all, in the US, volunteers. And of course, the way this works in other countries depends on the unique situation of that country. The phased approach is simply based on demand, on supply. Sorry, I mean, initially the supply of vaccine was much lower, as we all know. The Pfizer and the Moderna vaccines were approved under emergency use authorization in not all countries. I think, the EU, for example, was a little late because they decided we're gonna make this decision as a group of countries, whereas individual countries like the UK and the US and others could make that EAU, the emergency EUA, I guess, emergency use authorization decision in a more agile fashion. Many places, but in the developed world at least, are well into this phased approach, so that many of the elderly have been vaccinated. People like me, over 60, have been vaccinated, and now we're starting to look at opening it up to people even 16 years old to 55 years old. The last item under strategy, I can't emphasize enough, and you see this in your day-to-day life, and that is that communication is key. It's key not only to provide information about where people go to sign up, how they sign up online, what happens if the site crashes or if it's difficult to get online. But in addition, there is messaging that critically addresses vaccine hesitancy. Different groups around the world, demographically or socially, if you look at these divisions, are quite ready to get the vaccine and happy to, and others are very hesitant for a variety of reasons. And vaccine hesitancy has been around from the start. This is not new, but it's remarkable how efforts can be undertaken to address this issue. I noticed Google is dedicating $250 million in grants to develop PSAs, public service announcements, to encourage people to get vaccinated. You may have noticed on your Facebook or LinkedIn account, I guess it is, on your LinkedIn account, that you can actually put a brand, you can put a symbol that says, I've been vaccinated. What we know is that the people from decades of research is that people who are hesitant are most likely to listen to people they know, people like themselves. And so going into the local area, going to religious leaders and respected community leaders, sports figures, and encouraging them to go public and to talk about the fact that they got the vaccine, that it didn't hurt, that they may have had some side effects, but that they were not long lasting, and that it's a heck of a lot better than getting COVID. That's very important. And that last point that I made, which is essentially, don't lie to people. Don't tell people, oh, it's fine, you won't, and lie is a strong word. You want to be honest with folks. Yes, you may experience, and many people do experience side effects, soreness at the arm, flu-like symptoms for a couple of days, but these will pass. Some people actually show risk profiles and show that the possibility, I saw one for the J&J vaccine recently, the possibility of getting a blood clot from J&J is so much more tiny than getting struck by lightning or dying from other causes of death. So let me move on and keep an eye on the time as well. Okay, I actually need to pick up the speed. Under capability planning, there is a great deal of planning around allocation, and that is, where should the vaccine go? At the end of the paper that I showed you, there's 6 pages, and it's pretty cool. It shows the supply. I'm actually going to deviate from, if I can get back to that paper. It's worth having a look at. Let's see. You know what? I don't think I'll do it. I think I'll just encourage you all to go to the paper and look at the last 6 pages. It borrows a 6-graph presentation of the supply chain from prior to the manufacturing of the vaccine all the way through to the post-vaccine administration. And it shows very clearly what the different steps are, and it describes where the risks are, where the highest risks are. And it also shows what the data stream is for collecting data from the very beginning, pre-manufacturing, to where the vaccine is picked up, to the need for kitting and putting kits together with not just cold chain protection, but also the other supplies that are needed, like the alcohol swabs and syringes and things of that nature. So allocation is important. Sorry, I think I went too far. Yeah. Ordering. There needs to be some process by which local level and regional level authorities can let national authorities know what their needs are. Do they need more? Are too many doses being sent to hospitals and they're not being used, and they need to now be allocated out to community health centers, for example? So there needs to be an ordering capability. And in distribution, it's obvious that there needs to be, with the Moderna and the Pfizer vaccine, there needs to be no break in the cold chain. And so that transportation that's set up and the companies that are set up to do the transportation are critical. In Alaska, some of the transportation is done by dog sled. In remote areas in Africa, for instance, you have people, I don't know that they're taking, I don't think they're taking those 2 vaccines that I mentioned, but hiking into remote regions. The storage and handling of the vaccine is very critical. We've heard stories of someone who was cleaning up at a facility and they accidentally unplugged the refrigerator, and thousands and thousands, even tens of thousands of doses were lost. So there has to be capability for storing and handling the vaccine, which would include often a GPS monitor on the box as well as a temperature gauge. And that allows for tracking and tracing because it's critical to know where the vaccine is at all times. And then moving to monitoring systems, if you think about TOGAF or a layered model from the enterprise architecture point of view, we're really in the information system here. And so that's why we're down at the information layer part in the architectural model. And so there really is a need to keep track of the supply chain. That includes all the things that I just mentioned previously. What's been allocated. Shipping has to be tracked. The handling has to be followed. You have to know when vaccine's been received. All these things that happen before you as an individual show up to get your vaccine that have to be built. That capacity has to be built before you can get to that level of maximizing your vaccine administrative capacity. And then the obvious point really, that collaboration among these different partners that I've mentioned is really only possible to the degree that information flows. There's a major theme of the open group. The information really needs to flow digitally if possible. That's the world we live in, but it doesn't only have to be digital. And information needs to be shared safely, and so that there can be data analytics that are possible. Under vaccine administrative data, we need to know who gets vaccinated. I have a vaccine card. I guess you can't see it because you're looking at my, well, if you can see I guess you maybe can't see me. That's my vaccine card. It's very simple. It's just front and back. It's not laminated or anything. It says it's from the CDC. It says who it is. It's got my name on it, my birth date. It's got the name of my vaccination and when I took it. And that's my card. We can get into vaccine passports later if you want to. That's very much of a current issue everywhere. The last thing that I wanted to mention is research data. The need to do pharmacovigilance, I spoke briefly before, is quite key. And that is for the reason I gave. We do these emergency use authorization on the basis of clinical trials, hopefully. Not always, not in China, not in Russia, were these kind of clinical trials done. They were done later, but generally speaking, that is the approach that we follow. But it's only when you go out to millions of people, hundreds of thousands of people, and collect data on the response that people have to receiving the vaccine and collect other health data that you can do the kinds of health services research that's needed to determine true efficacy and safety. So pharmacovigilance surveillance is needed. Post-licensure clinical trials are needed. studies of the biology of infectious diseases, so better understanding the variants that we're dealing with now, and we may need to have booster vaccines to deal with these variants. The UK variant, the South African variant, the one in India now seems to be different still. So one needs to have these data in order to continue the biological research that's critical for the development of vaccines in the first place. Another reason for collecting data is to assess how effective mass vaccination campaigns are. And then, yeah, so I think I'll stop on that issue there. So my question to the audience really is, it's a call to action. The question is, how can enterprise architecture be used to help authorities develop more successful vaccination campaigns in the three main areas that I've discussed here, in terms of strategy planning, in terms of not just capability planning, but also capability development and the actual implementation, and in monitoring systems. So that is the end of my presentation. I think just briefly, feel free to contact me if you have any questions that you think I might be able to help you with, or people I could refer you to. I wanted to mention that I know a number of AeHIN members have been certified in TOGAF, and I'm learning as I go. I think I just celebrated 7 years at the Open Group, and while my background is more in health services research, I've by necessity become an enterprise architect, but one who is, I've had a certain skeptical view of it, because it's skeptical in the sense that I think there's something valuable there, but it scares a lot of people away. No question about it. And people take the training and come back and say, okay, now how do I use this? The fact is that there's so many different layers, not of how organizations function, which there are. And that's what enterprise architecture is about. What are the layers, and what are the services and business functions and responsibilities, and how are they related to one another, and how do you communicate that to people in charge? But there's also different levels at which one can communicate enterprise architecture. You don't have to just throw an Archimate model up on a screen and have like 30 items on it and expect people to understand what it means. There are some people that you will communicate very well using that kind of knowledge. But at a higher level, and especially in communicating to the people in the management model of the OHRA, it's sometimes more necessary to describe things in words and simple graphs. I think this paper is a bit of an example of that. Adding in the OHRA is for enterprise architects. If I were describing this to decision makers in national level jurisdictions, I don't think I would show them that. I think I would describe in common language the kinds of things that are needed. Archimate is a language that can be used usefully to show the relationships at the different levels of organizations. And then ISO, I think, is a phenomenal resource that HL7 contributes to, that IEEE contributes to, that the Open Group contributes to, that OMG contributes to. We contribute our standards there. That's a great place to go for quality, ISO 9000. And then there's an ISO, what is it, that we have been looking at for standards. And this is what we're doing in the forum now. It's called, the number is 13940. ISO 13940. The amount of standards and the detail is great and remarkable. And in your standard information base, you would want to refer to those kinds of things, depending on the project you have in mind. So let me stop there.
Jason, this is Alvin. Thank you. We have a few minutes. There's a question on the board. It's not actually on the mass vaccination campaign. It's from Irina, who's TOGAF certified, one of our advisors at the Regional Enterprise Architecture Council for Health of AeHIN. I have read that FHIM supports fire transformations of FIM objects to fire resources. Where are those transformations to be found, and what version of fire is supported, and is it maintained or updated for new fire releases? Over.
Yeah, that's a great question. And I'd love it if you would contact me. I didn't get all that information, but I have bad news. I have good news and I have bad news. The good news is there's opportunity. FIM can be used, and there's a paper that's available on the FIM. Well, you can go to the FIM website and look at the FIM Profile Builder, FPB. We developed that. We have a diagram. It goes into substantial detail. And what it shows is that it can be used to create fire profiles that are useful, not just from one hospital to another hospital or one part of a hospital to another part of a hospital, but can be mapped to many hospitals, because the FIM itself, the Common Information Model, can be mapped to other standards that people use. And it's only when you use a common information model that fire resources become reusable. The criticism about fire resources and the Fire App has always been that in order to use the fire, you have to basically get the two organizations that want to exchange data together to agree on how they're going to refer to various clinical terminology. And they have to get it exactly right. And once you've done that, then fire becomes, this great resource, and people are using fire, but there is still that limitation. Unfortunately, the FIM does not have the support yet to take it beyond, to take it to where it can go, which is to create those kind of reusable fire profiles. Happy to talk to you about it more. We're looking at the open group for large organizations who would come in and support that kind of work.
Thank you. Russell Gan, who's also one of our architect advisors in our last workshop in Laos, is asking how they can access the slides. So I gave him your email address, and maybe anyone else can just email you for the slides. But I know the vaccination document is freely downloadable.
Yeah, it's the vaccine paper is better than the slides. I mean, I'm happy to give you the slides. Just email me and I'll send them to you. But really, that paper is about 20 pages long, and 6 or maybe a little longer, but the last 6 pages is the McKinsey supply chain. So I would highly recommend you go there. It's pretty readable.
Okay, which brings me to a comment and a question, and maybe to inform the people in the call that AeHIN is actually an organizational member of the Open Group Architecture Framework Healthcare Forum. Jason is our facilitator, convener, and we are learning a lot in the forum. We have access to the artifacts. So maybe my question to Jason is, the artifacts that we are able to access as AeHIN, how much of that from the healthcare forum, how much of that can we share with our membership?
That's a great question, because you are an association rather than
we're a loose network. Yes, we do have a subscription mechanism where they sign up to our mailing list, but so, there's no there's no subscription fee. They're many of them are from ministries of health and government agencies.
Yes, I would say, so that's a great question. Anything that we have published, you can share. I mean, you can share because it's open. My preference would be that rather than you downloading it and sending it to people, they would go and download it themselves, but it's free. So that's all shareable. Things that you receive from me, Alvin, that talk about what we're doing now within the forum in developing a global hospital reference architecture, that information is restricted to the members of the healthcare forum itself. So that's not as shareable. That would be considered proprietary data.
So for example, we're working on the hospital reference architecture with the Dutch NICTIS and stuff like that. So those things are still under development. And so that's why we can only discuss it in the forum. You did inform me that if anyone who's a member has an AeHIN.net domain can join the meetings.
You bet.
Yeah. So let's make an invitation to the people in the call that if you want to participate in the forum, let us know so we can create an AeHIN.net account for them. That allows them to participate as an AeHIN member in the forum discussions, but still bound within the confidentiality of things that are still under development. But that's an invitation to the people in the call.
Yeah, I'm glad you said that. And we meet on Thursdays at 8 a.m. Eastern time. So this time on Thursdays, it's the work that we're doing with hospitals. It's slow because hospitals are complicated organizations, but we want to break it up into several pieces. If you want to see a little more about the Zira, you can go to www.ziraonline.nl for Netherlands.
Zira
online. I can't put it in chat.
Right. Okay. So
just someone else would.
Just to inform the people in the call that because I'm a CIO of 2 hospitals, it really helps to be a member of the forum. If you can join as your institution, not with AeHIN, that really helps a lot as well. But if you want to join first as an AeHIN member, then to see what happens in the forum, you will learn a lot. I mean, there are hospital architectures that we can learn from the healthcare forum. So that's something I'd like to relay as an invitation to the members in the chat right now. Could we get a link to the vaccine paper? I think you need to paste it right here.
Okay. Well, the vaccine paper. So at the beginning, so all you need to do is go to www.opengroup.org. Let me get back there.
Type it already. Yeah.
Yeah, let me get back there because it's so easy. I mean, the link really, we don't want to go there. If you go to www.opengroup.org, just like that, you don't have to sign on or anything. You can just go right here and get it. Now, what I'm going to do, this is the link. So I'm going to copy that. How do I put this on? Let me see. I'm screen sharing. Here's chat. Let me put it in the chat window.
Right.
There we go. All right. There's the paper.
Okay, good. And they can cite this if they want to make this part of their documents when they're designing their systems. They can cite this paper because it's.
You can cite the paper, absolutely. And you know what? If you're interested in the slide deck, I know someone asked earlier about the slide deck. It's in our interest, it's in the world's interest to share this with you, really. And if you wanted to take the slide deck and make it your own, or just take some slides and maybe probably leaving the open. I I'm just thinking my company probably would not want me just to give this away, but you can certainly use anything if you just cite us.
Fair
And
use.
I would be happy to provide this PowerPoint presentation if you'll just, I think every page has the open group on it. So if you'll just cite where it came from, you know, I'm 100% encouraging you to do that and share it with anyone in your sphere who you feel would be, you know, could benefit from it.
Okay. Thank you, Jason. That's very generous. So we've reached the top of the hour. Thank you, Jason. I hope we can get you again, maybe 3-4 months from now or earlier.
On the
if we
hospital stuff.
Right, on the hospital stuff, right? We're very excited about that. I'm the CIO of a hospital, and you know, you need architecture when you talk about hospitals because it just gets very complex without one. So
Yeah.
thank you, Jason, and we'll see you.
Thank you so much.
Thank you, everyone. Bye-bye.